So how would you address the inflated COVID-19 death rate, and how would you handle, I mean, for $10,000, I understand the motivation, but how do we resolve it so we get an accurate count? And
I think we need to have our leaders in both state and federal situations call forth an audit. I think that we need to let hospitals know and physicians know that there will be an audit and that there will be an effort made to determine whether or not a COVID-19 diagnosis was appropriate. Was there a laboratory confirmed test? Did the clinical symptoms justify consideration of COVID-19? If a person comes in from a motorcycle accident and a collapsed lung, and on some admission laboratory tests, it's identified that that person has COVID-19, but 2 hours later the patient dies of shortness of breath, respiratory distress related to the collapsed lung, that's certainly not a COVID-19 death. Do I think it's possible that there's an overcount in some situations of COVID-19 disease? I do. Do I think overall there's an overcount? No, I think overall there's an undercounting of disease, because for every person that has had it identified, there's probably another 10 to 50 people who have had it that never had it identified. I think when we talk about the concern with overcounting, we need to look at discharge diagnoses that potentially would bring in more dollars and death rates, because death rates are informing our public policy. The case fatality rate is being used by politicians and bureaucrats to do lockdowns, contact tracing, masks, and a variety of other rules, including school closures and, quote, non-essential business closures. Though I'm still not certain how anybody would look at the thing that they do for a livelihood as non-essential. That one blows me away.
on the non-essential, so all government workers who have a simple classification of their job are essential, and all taxpayers could be non-essential. It just kind of seems discriminatory against the private sector versus public. And in New York City, they kept the subways open for the essential workers, and they spread the disease throughout New York and New Jersey because they never washed the subways, because you can't kick the homeless out. They're homeless, they got nowhere to go. Therefore, they're urinating in the trains, they're staying in the trains, and they're just infecting them. And they weren't cleaned for the first 66 days. That's why New York and New Jersey had such a spread, is because the governor never washed the subways. And you had to move because of the subways, so people sat in a petri dish. And there was just no debate. And half of it had to do with the fact that they were essential, so they were immune. So how does being essential personnel help with your immunity to an infectious disease?
I don't know of any documented relationship between an essential business or an essential person and how that motivates or doesn't motivate the immune system to be efficacious. That's not something that I've been able to find any articles on.
Are you familiar with the term herd immunity, and what does it mean?
Herd immunity is something that veterinarians have been utilizing conceptually for far longer than physicians, but it is what it is. My wife's a veterinarian, and oftentimes veterinarians would go in and immunize an entire herd in order to not allow a vector of transmission, whether it be viral or bacterial, into that herd and into new calves and animals such as that, perhaps new calves, new animals brought into the herd. What it means for humans is, how does a society, how does a group of people become immune to a virus or a bacteria? And there's numerous ways that you can develop herd immunity. One is to get the disease and develop an immune response, whether it be antibody or cellular. And at that point in time, if that immune response is memorable to the immune system, you would be immune. Another way to get immunity is passively, not getting the disease, but passively through a vaccine. And then the vaccine would hopefully arouse an antibody or potentially a cellular immunity. Those are the two big ways. But sometimes we forget to discuss the fact that there's also a thing called innate immunity or even a disease resistance. We know that a fair amount of the population couldn't get leprosy if they put the bacteria on their Cheerios. And yet there's another group of people in the society that is susceptible to leprosy. We've known this for hundreds and hundreds of years. So herd immunity is achieved through either getting the disease, being intrinsically resistant to the disease, or utilizing a vaccine. And with different diseases, based on the level of infectiousness and contagiousness, the percentage of people in a group of people that need to be immune varies. With measles, we usually figure you need to have 90 to 95% of the population immune in order to protect the 5 to 10% that aren't. Conjecture has been put forth by numerous people regarding COVID-19 that it should probably be somewhere around 60 to 70, 75%. And yet, we're looking at some countries who have demonstrated 20 to 25% detected people with antibody immunity. And some of these countries are discussing the fact that they could be nearing herd immunity, which would imply that there must be some cellular immunity that we're not aware of. There might be intrinsic disease resistance. And if we go back to some of the pandemics, it is exceedingly unusual for any pandemic to produce more than 30% of the population producing antibodies, detectable antibodies to the disease. So when we throw a number out like 70%, that's not something that we ordinarily have seen with previous epidemics and pandemics. It's very unusual to get higher than 30%.
Speaking of that, there was the Hong Kong flu in 1968 and 1969. There was no mask, there was no mass panic. As a matter of fact, we had the Summer of Love and Woodstock. How has past pandemics, like the Hong Kong flu, which we had 100,000 Americans die, but a population of 203 million. We now are around 330, and we just hit 160. Once you adjust those numbers for inflation, the corresponding death rate to the Hong Kong flu is right about where we're at today, which is 160,000. But there are no masks. There was a Summer of Love. Everybody was running around Woodstock half naked, jumping on each other, and there didn't appear to be a breakout. Nobody remembers the Hong Kong flu. How can you have a pandemic with no masks, with less death rate, and now we have all these masks, all this political drama? What was different about the Hong Kong flu and the way it was addressed?
I think the biggest thing that you would see between the epidemics in 1957, 1968, 1976, the various epidemics we've had in the last 20 years, is we have different leaders at the helm. That makes a difference. And I think this time around, for whatever reason, we're seeing politicians say, we can't trust the people. Looking at some countries, there have been many countries around the world that have leaned into the citizens and saying, this is what we need to do, we're in this together. We certainly haven't seen that in Minnesota. In Minnesota, we've seen a heavy-handed, top-down approach, and there's been no particular, let's lean into the motivation, the energy, the thoughtfulness of the citizens. Minnesota's always enjoyed a reputation as having a wonderful citizenry. I think we deserve that reputation. But I think, for whatever reason, in this pandemic, we're not leaning into those folks, everyday folks. And people have asked me, what would I do differently than Governor Walz? That'd be a huge thing. I would say, tell the people the truth. Don't compromise your integrity by trying to coach or massage physicians and death certificate certifiers to get potentially padded numbers. Don't do anything that could even remotely look like that. remember that the greatest thing that you have to protect is the trust. If you protect the trust and then lean into the citizens and say, this is what we need to do, a lot of these draconian measures wouldn't be necessary. And we would be far more likely the one Minnesota that Governor Walz talked about when he was campaigning. We are not one Minnesota. We are one fractured state. And it's terribly sad. And we will forever remember the fact that not only did we take no significant action to protect our vulnerable elderly folks in long-term care facilities, we had decision makers create a pipeline of active COVID-19 disease from hospitals to the nursing homes. And then, when the COVID-19 was detected in the nursing home, the patients, the residents were told, you're here to stay. This is lockdown time. And if you get the disease, by the way, you can't have any visitors. You won't be having your loved one there. And if this disease progresses and takes your life, you're going to die alone. That will be a lasting legacy from this pandemic and the public health response that we'll all have to live with.